Hi, my name is Dr. Ken Fujioka, and I'm Director of Nutrition and Metabolic Research at Scripps Clinic in San Diego, California. And today I'm joined by Carol Weisham. She is over at the Multicare Rockwood Center for Diabetes and Endocrine. She's technically a very, very good endocrinologist in beautiful Spokane, Washington. And we're going to cover incretins and glucagon. And I know these are not typically hormones you use or work with. GLP-1, sure, but not GIP, not glucagon, but they have a place. Dr. Weisham, why don't you kind of fill us in on incretins, glucagon, and how they work?
Oh, thank you. And Ken, it's delightful to be working with you again after all these years since our last opportunity to work together. Um, so the incretins are hormones, as many of you know, that are secreted by the cells in the small intestine in response to meals. And there are several incretin hormones or hormones made by the intestine in response to meals, but there are two major ones that are involved in glucose regulation, and those being GLP-1, which you're very well aware of, as well as GIP. Now, what we know in normal physiology that GIP actually has a greater impact on insulin secretion and actually accounts for about 45% of the insulin that's secreted after meals. GLP-1 about 25%. That means that glucose itself only is responsible for about 25% of the insulin secretion. I think that's really a key point to understand why these hormone therapies are so important. Now, if we look at the incretin hormones, GIP and GLP-1, studies in normal animals and in normal humans suggest that they have synergistic effects on insulin secretion as well as weight reduction, but they do have opposing effects on glucagon secretion. It is, again, important. These hormones work best when they are used together as opposed to one or the other. Now, GLP-1 receptor agonists have a specific impact of decreasing gastric emptying, whereas GIP has very interesting effects on adipose tissue. It actually enhances the ability of lipids to be stored in the subcutaneous tissue, which does two things. It significantly lowers triglycerides, but also helps to prevent ectopic fat distribution in our patients. Say, Ken, GIP has an effect on both alpha cells and beta cells. Can you fill us in a little bit about the study that was recently done to demonstrate that?
Sure. So, again, these two hormones were meant to work together. So, when you're looking at GLP-1, something we're very used to, it's very good at lowering glucagon. And so, always remembering beta cells secrete insulin, alpha cells secrete glucagon. But GIP is a fascinating hormone because at high levels of glucose, it's very good at actually helping lower glucagon. But once you start to get low glucose levels, it can actually go to the alpha cells and produce more glucagon when you need it. So it's a very complicated but very useful hormone for human beings. We need it. And it also has the ability to get crosstalk between the alpha cells and the beta cells. So again, it's part of this picture. And think of food coming down the intestinal tract. It first actually hits the K cells, which are in the first part of the intestine. And then as it gets down further to the L cells, then it'll release GLP-1. So again, they're meant to work in concert, but GIP is very unique in that it is able to actually increase glucagon if you need it.
Great. Well, thank you. That's very interesting.
Okay, Carol, then what happens then when things go awry in, say, the patient who struggles with obesity and type 2 diabetes?
So, what we know in patients with type 2 diabetes that they have an impaired incretin effect. They do not secrete as much insulin in response to a glucose load as a person who's normal. And the difference, the incretin, the effects of the incretin are blunted. What we do know that if you improve glucose levels in our patients, that their responsiveness to GLP-1 will actually improve. Now, in isolation, the studies that were done early in patients who were hyperglycemic, GIP had very little effect on insulin secretion. But when they found that and they normalized the glucose level and then used GIP, they could show a recovery of some of the responsiveness to GIP in patients with diabetes. As far as glucagon, we know that patients with diabetes typically have elevated glucagon levels, and we know that acutely, if you give GLP-1, you'll actually see the suppression of glucagon, whereas GIP stimulates the glucagon. Now, as we all know, glucagon will raise glucose levels, but also has a specific effect on satiety. So I think it's important that it not be looked as the bad guy in this situation. And then, of course, we've talked about in the normal individuals, these two hormones work in synergy. They work together to improve insulin sensitivity. And of course, preclinical research actually suggests that GIP receptor activism is associated with some antagonistic activity as well as agonist activity, especially as it relates to the glucagon, but also really importantly in the brain. There are specific GIP receptors in the brain that have been shown to be activated and are in part responsible for the reduction in food intake.
Carol, why don't you walk us through these studies, which really have some very good learning information?
Yeah, well, looking at an agent that is a dual agent, GLP-1 and GIP, called tirzepatide. And when given to mice, what they were able to show is that there was an improvement in insulin sensitivity, which was weight dependent as well as some that was weight independent. And by testing these in specific types of mice that don't have GLP-1 receptors, they were able to demonstrate that it was activation of the GIP that accounted for the weight independent insulin sensitization, which I think is really important. And by doing that, they were able to show not only increase in glucose uptake, but also improvement in free fatty acids, as well as oxidation in brown adipose tissue.
So when we kind of bring this all together, because you folks are going to have these hormones available to you in the very near future, think again as humans trying to control glucose, that it's multiple hormones, not just insulin, not just GLP-1, but GIP, and there may be even some others that we're still trying to figure out. And when they work together, which is really the future, putting these various hormones together in the right concentrations, which we're kind of learning at this point, you're going to be able to get very impressive control of glucose. I mean, you're going to see A1C drops much more than things we've seen before, even better than insulin, which we'll talk about in the next section there.
Hello, my name is Dr. Carol Weisham. I'm a clinical professor of medicine at the University of Washington and a clinical endocrinologist at Multicare Rockwood Center for Diabetes and Endocrinology in Spokane, Washington. I'm joined today by Dr. Ken Fujioka. He's a director of nutrition and metabolic research at Scripps Clinic in San Diego, California. Welcome, Ken.
Thank you.
And Ms. Brittany Jones, a patient with type 2 diabetes and an advocate for others with type 2 diabetes from Atlanta, Georgia. Welcome, Brittany.
Hello, thank you.
In this section, we'll be considering the question, what is the rationale and the latest evidence for use of incretin-based dual agonist therapies in patients with type 2 diabetes and obesity? So Ken, you devoted your career to the management of obesity in patients with and without diabetes. You would be a perfect person to give us a brief overview of the GLP-1 receptor agonists.
Okay, so GLP-1 receptor agonists are essentially part of a whole group of hormones we call satiety hormones. And the reason why I'm bringing that up is all these other hormones we're talking about are going to be in that group. So you eat a meal, you get food into your small intestines, and you start to release hormones to control insulin release from the pancreas, and also going to the brain and telling you to stop eating, satiation. So very, very important. And we know GLP-1 is probably better than anything because there's been so many really great studies. But the future is going to be combining GLP-1 with multiple other satiety hormones, because they really work so much better. And if you look at the other talk that Carol and I just had, it's real clear that when you combine these two, you get much better effect, particularly on glucose control. Very, very impressive.
So GLP-1s, they have a mechanism of action that we understand well. They are released by the intestines. They go to the pancreas, stimulate insulin, suppress glucagon. They go to the stomach, slow gastric emptying into the brain, as you pointed out, decreasing food intake. They can be given injectable, daily, weekly, and now available as an oral medication. And they have an impact to lower A1C by about 1%, maybe 1.5%, weight loss in the 2 to 3 kilogram range. But importantly, they've been found to be safe, low incidence of hypoglycemia, very, GI side effects are relatively common, but are manageable. And they have great outcomes for cardiovascular effects and decreasing cardiovascular events. So the tried and true GLP-1 receptor agonists are still incredibly important in our day-to-day armamentarium. So, Brittany, I am really interested to hear about that first visit to your primary care provider where you came in to discuss your diabetes management and your weight. Can you take us back to that day?
Yes, ma'am. I went into the office to go over my A1C as well as my weight. Weighing in over 300 plus pounds, and A1C was right up 12.3, 12.5, right up in there. I started asking my doctor about different things that I could do to control my A1C as well as getting my weight under management. And I first mentioned to him about having a gastric surgery. And then he introduced me to a new medication that I could take once a week. And he stated that it was proven, to help with weight loss as well as the control of my A1C levels.
What other questions did you have for your doctor about this new medication? Certainly, there must have been something in your mind in terms of potential concerns.
Yes, ma'am. I was pretty much worried about the side effects. Could it cause any harm to my kidneys? Was I able to take it alongside the other medication that I was taking? And pretty much its overall effects of my health.
And tell us, how did it work?
As of right now, I am down 40 pounds. My A1C went from a 12 to 8.3, and I just had that checked 4 days ago. Um, Overall, I'm feeling a lot better. I'm a little bit more confident. I am not eating as much as I used to. I'm very mindful as well as conscious, but overall, I'm more active.
That's great. Well, congratulations. So, Brittany, did you experience any side effects related to starting the semaglutide?
Yes, ma'am, I did. The side effects, they were pretty much mild. It was, I was feeling really fatigued after 2 weeks, as well as a little nauseated. And I wound up incorporating a multivitamin and pretty much just drinking a lot of water, cutting back on the zero sugar drinks and just incorporating more water.
Do you have any other tips for patients on how to manage the nausea?
Yes, ma'am. Pretty much just be mindful of what you eat. Start logging what you eat and see how your body responds to it.
That's very important. Making smaller serving size, I find, is very helpful for patients. So back to you, Ken. You've already introduced the concept of these incretin-based dual agonist therapies. Can you review some of the latest data from the phase 3 trials for tirzepatide, just overall?
Sure, I'd be happy to. I'm going to actually start with Surpass 3 and Surpass 4 only because they're comparators. They're comparing a GLP-1 and a GIP together as one, tirzepatide, against insulin. And we all know that when you have a type 2 diabetic and you give them insulin, they typically will gain weight because insulin is really good at not just putting sugar into cells, but putting fat into cells. And so if you look over there at the drop in A1C, it is impressive to see that you're dropping your A1C about 2 to 2.4%. I mean, that's a pretty darn big drop in A1C for basically 1 year study. And if you move over to the weight change, as expected, insulin, you gain 2.5 kilos, 2 kilos. But when you look at the effect on weight with GIP combined with the GLP-1, now you're looking at rather impressive weight loss. I mean, this is as good as, big dose semaglutide, which they use for weight loss, but you're looking at, 12, 13, 14% weight loss. So again, very good weight loss. And again, it's because you're using the two together, you're getting much more satiety effect and you're lowering the food intake. If you look at
Yeah.
Surpass 2, they actually compare it to a GLP-1 semaglutide, but semaglutide at 1 milligram is really a diabetic dose. You're getting pretty darn good changes in A1C. And if you look at the A1C relatively this one, it drops about almost 2%, 1.9. But if you look at, again, tirzepatide, you're dropping your A1C 2 to 2.3%. Again, very, very impressive. If we go over to the weight change, again, you get this 12 to 13% weight loss versus, 6, 7% weight loss. But again, that's at a diabetic dose. So again, not always fair there. And I don't know if they have bigger doses coming down the line in other studies, but at least comparing these two, again, you're getting this impressive change. The bottom one is just your standard placebo-controlled trial with about 475 patients. And again, as expected, when you take patients with type 2 diabetes, particularly when they're not adequately controlled and you bring them into control, don't be surprised if you get a little bit of weight gain because you're not peeing off as much sugar and things like that. But again, you get weight gain in the placebo group and you get, again, weight loss in the patient that gets tirzepatide.
I think importantly, that last study was on top of glargine insulin, suggesting that even patients with longstanding diabetes respond well to these medications. So thank you for that. So there is some studies, as you may or may not be participating in, for tirzepatide in obesity. So those are the SURMOUNT trials, and we look forward to seeing. They are going to be using the same doses as they did in the diabetes trials, as I understand it. So Ken, there are other agents in early development that we consider dual incretin-based therapies, two of which are GLP-1 and glucagon dual agonists. Can you review the very minimal data we have with these agents up to date?
Okay, sure. So this is where it gets a little tricky, but if you look at their now phase one, whether it's phase 1A or 1B or whatever, you're just trying to find out, is what I'm giving safe? You want to make sure you don't want to hurt anybody. So it's the very first in human studies. But if you look at their phase 1B data, and we're talking just 16 weeks, so very, very short period of time to get 14% weight loss, this is basically as good as bariatric surgery. So again, impressive weight loss in the obese population.
Well, and there's one other, also a dual GLP-1 glucagon cotatutide. Sorry, cotadutide. Could you give us just a brief highlight of that as well?
Okay, so again, one of these where they're notice that they have, so it's a 2B, so they're dosing. They're trying to figure out what dose is going to work, what's going to be my best one. So they got 3 different doses here, and their comparator is either placebo or liraglutide. So it is open label. But if you look at the A1C drop in just 14 weeks, it's over 1%. And again, that's only 14 weeks. That's not a 1-year trial or anything like that. The weight loss is pedestrian. It's 3 to 5%. But I mean, again, not bad. And again, these are type 2 diabetics, so I'll take it. But they who knows what dose they're going to end up with, again, because these are, to me, these are the hardest studies I do, is when I'm looking at different doses.
Well, we've given you some brief information concerning medications that are hopefully going to become available in the near future, the incretin-based dual agonists. Um, when they do become available, which we expect the first to perhaps be available by the end of this year, how, we have to just imagine how they might be used in the ADA treatment algorithm. And again, until we have cardiovascular safety, it'll be hard for them to replace GLP-1 receptor agonists for those with cardiovascular disease. But I could envision that, particularly for people who have a great interest in or need for a larger amount of weight loss than they can get with a GLP-1 receptor agonist, that tirzepatide might replace the GLP-1 receptor agonist in the ADA treatment. And Ken, your perspective on the management of obesity with these agents, is that something that you think that you will be using when they become available?
Oh yeah, the future will be using multiple satiety agents of these classes together, because you're going to get much better effect, much more weight loss, and you may even be able to use lower doses of each one because again they work pretty much synergistically.
That's great. Well, thank you for your insight. And Brittany, thank you for your comments as well. And I hope that you found this to be helpful.
Hello, my name is Jennifer Okima. I'm a registered dietitian and a certified diabetes care and education specialist, also formerly known as a certified diabetes educator. I own a company in the Seattle area in Kirkland, Washington called Salute Nutrition. I'm in private practice. I am a multidisciplinary care of diabetes educators. I'm joined today by wonderful Dr. Carol Weisham. She is a clinical professor of medicine at the Rockwood Diabetes and Endocrinology Clinic in Spokane, Washington. Thank you so much, Carol, for being here. And I'm very excited. I'm very excited to welcome Brittany Jones. Brittany lives in Atlanta, Georgia, and she is a patient and an advocate for others with type 2 diabetes. In this section, we're going to be considering the question, how does early treatment, intensification, weight loss, and patient education improve outcomes in patients with type 2 diabetes and obesity? Dr. Weisham, would you mind going over the benefits of early treatment and the intensification in type 2 diabetes and the effects on long-term outcomes?
So I think this is a really good question, because more and more we're getting data showing that people who are able to achieve their glycemic targets within the first 6 months to 1 year after their diagnosis have fewer long-term complications, both micro and macrovascular complications. So again, we have early data now to suggest dual therapy from the beginning is better than step therapy by adding to, an agent only after somebody fails the first treatment. So it's really important to start early, start aggressively, and to intensify quickly to get the best glycemic control. And particularly in our obese patients, medications that can help with weight loss, which also has further effects on complications of type 2 diabetes.
Thank you. Brittany, when you started your new therapy, your new medication, were you concerned about long-term complications with type 2 diabetes? Have you had that discussion with your doctor?
Yes, ma'am. My biggest concern was, would I develop any sort of kidney failure, strokes, and, just not being able to have a good quality of life for my children.
That's a primary motivator, isn't it? Dr. Weisham, traditionally, medications that we've used in type 2 diabetes, from sulfonylureas on up the line, have caused weight gain. And we were very excited once GLP-1s were on the market and were deemed safe. Can you explain and talk about other medications as well as GLP-1s on the effectiveness on weight loss and the benefits of that?
Yeah, if we focus on those agents that are designed as their anti-hyperglycemic agents, we have the GLP-1 receptor agonists and the SGLT2 inhibitors. And obviously, if a patient has cardiovascular disease or has renal disease or heart failure, it might cause us to choose one over the other. SGLT2 inhibitors, for instance, in patients who have heart failure. I think the most important aspect when you're looking at choosing these agents, both of which will cause some weight loss, is that the amount of weight loss that we expect to see is greater with GLP-1 receptor agonists. So we might choose that in a patient in whom weight loss is a prime goal in addition to glucose control. But they are also a little better at reducing glucose levels. So again, those with very high A1Cs are likely going to do better in GLP-1 receptor agonists. But to be honest, when we're talking about a second-line therapy after metformin, an awful lot of people who don't have a clear indication for a injectable are going to prefer an oral medicine. And so we have the SGLT2 inhibitors as a second-line therapy. And now, more recently, we have an oral GLP-1 receptor agonist that can also be used as second-line therapy. But importantly, as I pointed out, look at the patient, their comorbidities, and involve the patient in helping to make the decision about what their preferences are.
That's a great overview. Brittany, you have a remarkable story of going into your provider and wanting to discuss gastric sleeve for weight loss. But instead of discussing gastric sleeve, your physician brings up this new medication that you had not heard of before. And you tell me, what did that mean to you when your doctor brought up this new medication? Tell me about that.
First, I guess I was asking myself, would it work? To be honest, because it's like, okay, here's another medication to go on top of the other medications. Will it really work? Will it really give me the benefit that I was looking for, which is the lower A1C? Will it really help me lose weight? How fast would it help me lose weight? And just asking myself, would it really work, to be honest?
Were you provided with diabetes education on how to take the medication, what to expect when you took the medication, how to change the doses, anything, any kind of guidance like that?
No, ma'am. What I had to do was pretty much do a little research on my own on the web and just kind of come up with things that I felt that'll work for me.
Well, fortunately, this is a medication class that benefits well from diabetes education because it's with the right education, you can be guided through how to take it, when to take it. What if you forget to take an injection? And then also, if you have the expectations, or even if you weren't given the expectations on the potential side effects. Were you given the expectations that there would be some side effects with this medication?
No, ma'am, I wasn't. I had to pretty much just, like I said, look on the web and kind of get into different little Facebook groups and see how everybody else was relating to the medicine and jot down a few tips here and there just to kind of look out for those different things.
I'd love to add my perspective here, and that is I have a lot of patients who come to me having already, quote, tried these medicines and couldn't tolerate them, and yet they didn't have any education. And stepping back and stepping them through how to minimize the side effects made all the difference in the world, and they're doing well on them these times. So I think that's really imperative that appropriate education be given to maximize adherence to the medication.
That's a great point. A lot of times I find that patients feel that maybe a sense of nauseousness and they think that it's a terrible side effect of the medication, but the medication is supposed to pump your brakes and tell you that your meals should be smaller, the fat content should be smaller. And that's one of the mechanisms of how it works. And it's fantastic when you're guided through that because then you know that that's a normal process. It doesn't have to be debilitating nausea at all. There's ways to work around that. Brittany, I'm excited to hear that the side effect, the lovely side effect of the medication was weight loss. What did that mean to you when you started seeing some of your weight come down?
It made me keep going to incorporate exercising and just to overall it just made me push harder to achieve the goals that I was looking to achieve, if not more.
That I think is one of the understated sort of positive side effects of this medication class is the level of engagement we get with our patients. Just like Brittany said, once the weight starts to come off and they feel like something is changing and something's happening, we have a different level of engagement. Dr. Weisham, have you come across that phenomenon as well?
Absolutely. Absolutely. People come off their antidepressants. They obviously, there's other medication changes, but when they start seeing themselves succeed at weight loss and improve glycemic control, it's just a positive feed forward cycle that maintains itself in many patients. I think it's important at this point to discuss the medical reasons and importance of weight loss. I mean, weight loss not only helps patients feel better, which is really important, but for those of us prescribing this medication, we want to see the glucose level improve, and having further weight loss will help this medication improve the glycemic control over the long run. And of course, with weight loss, we get improvement in insulin sensitivity, which of course decreases inflammation and the ectopic fat that tends to cause more insulin insulin resistance and problems. And then finally, I think it's so important for us to be thinking about weight loss in a completely new way, because we have got so many comorbidities of obesity that coexist with our patients with diabetes: cardiovascular disease, a fatty liver disease, heartburn, incontinence. You can just name a number of complications and symptoms that could be improved by weight loss. And I forgot to say sleep apnea. So by really focusing on weight as a primary outcome in patients with diabetes, I think the time has come that we are changing our focus, and that's going to be one of our prime goals.
Well said. Well said. Dr. Weisham, how do you use diabetes educators in your practice, and what is the role that they serve?
That's a really good question, Jennifer. First of all, I'm very fortunate, and I have diabetes education embedded in the same physical space as I have my clinic. So they're just right around the corner. They do everything. They take all the patient phone calls. If the patient's having problems with their diabetes control, they answer the messages that people are having problems with their control. They obviously do education at diagnosis. We try to get our patients in annually for that, as well as when we start them on new therapies. So if we're starting them on insulin or we're starting them on a GLP-1, we'd like them to see the educator. We do also work with primary care, and we have a really big outreach for our educators to go and spend some time in the primary care clinics, much as what I know you do. Now, we also have pharmacists now that are going into primary care, which will also be working alongside the primary care provider for helping medication adjustment as well.
That's great. I find that many healthcare providers don't quite understand what we do, but as soon as we are able to show them our scope of practice, they wonder what they did without us. We're very patient-centered. One of the techniques that we use for education, like we would have done with Brittany, is very individualized care, meaning that whatever the concern is of the patient, whatever's important to Brittany, that's what we talk about and that's what we focus on for her care. Just a little plug for a diabetes care and education specialist. We are nurses, registered dietitians, pharmacists, social workers. We're a multidisciplinary team that our focus and specialty is helping people and guiding them through diabetes education, medications, lifestyle, all sorts of things. There's many different points at which we are most effective in helping patients when they're first diagnosed. Every year, it's an annual benefit on almost every insurance, so we are covered. If any sort of complications occur, if there's any kind of change in care, any kind of change in medication, those are all points that you can meet with a diabetes educator. You can meet with a diabetes educator with or without a referral from your provider. It's not a difficult thing to do. You can go to diabeteseducator.org and find somebody in your area. But if I may, I would like to ask Brittany, how do you think your journey with this medication could have been different if you had somebody sit down and talk with you, show you how the device worked, talk to you about expectations of the side effects, and guided you through that?
I think that I would have achieved my goals a lot sooner. because of course, if you sit down with a person, they're going to tell you how to meal plan, what you actually need to consume to keep yourself going, as well as giving you the proper nutrients. Also, how to manage the symptoms and your care with those symptoms, just to give you that encouragement.
Brittany, you've had a very interesting experience. You're using a medication that's working fantastic for you. You still have a journey with type 2 diabetes. It's going to be with you. So I'm wondering what your thought is about future diabetes education and where that might fit in for your care.
Well, just for people to kind of learn a little bit more about this disease and how it overall affects your body. That's what I'm trying to learn and trying to pretty much stay on top of my care, as well as the new things that are coming out to improve diabetes, and letting people know that you can live with this and you can live a healthy life with it, and it doesn't have to destroy you. I started a YouTube channel just to help others out, to let them know some of my daily tips and tricks that I do to help out with my A1C for as meal planning, and talk about different medications and how my body responds to those medications. Just pretty much just trying to help people out who have diabetes, to let them know that they're not alone, that they can reach out and ask various questions.
That is absolutely true. You can live healthy with diabetes. That you can do things in your life to help control. Education is the key to that. So thank you so much for sharing that. And I urge anyone with type 2 diabetes to get a good healthcare team that involves a diabetes educator.